Good evening, delegates. Thank you for joining Shweel Connect. And today we have Doctor from Hyderabad, Dr. Runa Acharya, and ma'am is going to take topic poor ovarian reserve. So before we give a little introduction of madam, let me give a little introduction of our webinar platform, shailconnect.in. So we have different sections available where blog section, you can find different blogs written by the doctors. Then we have the webinar section where you can find the upcoming webinars, and we have already done past webinars of around 929 webinars. So you can also check our webinar section. Then this is the key opinion leader section, so where you can find all the detailed profile of our speakers who are connected with Shweel Connect. And now let me introduce Dr. Runa Acharya, ma'am. Ma'am is senior consultant in fertility solutions. Ma'am has done MBBS, MD, obstetrician and gynecology. Ma'am is working with the Medicover Fertility in Hyderabad. So ma'am, we welcome you on our platform for today's webinar. We are glad to have you on our platform, ma'am. And I hand over the session to you, ma'am. Thank you.
Thank you, Nishan, for the kind introduction. And a good evening to all my viewers there. And I think I would like to share my screen now.
Sure.
Yeah. So the topic for me today is poor ovarian reserve. And I think it's one of the very vast topics, and I would try to concise it to the best of my ability and bring forth whatever the newer data or whatever the newer evidence has to talk about. I bring greetings from my city of Pearls, Hyderabad. I'm working as a senior consultant at Medicover Fertility, Hyderabad. So when we coming to poor ovarian reserve, so let's first understand what could be the definition given by the ASRM is that ovarian reserve is defined as a number of oocytes remaining in the ovary or the oocyte quantity, that is the ovarian oocyte number. And diminished ovarian reserve would be the loss of the normal reproductive potential in the ovaries due to a lower count or quality of her remaining eggs. So when we talk about poor ovarian reserve, this indicates that there is a reduction in the quantity of the ovarian pool, follicular pool in a woman of the reproductive age group, and is very important cause of infertility in many couples these days. The decline in the natural fertility occurs earlier, but it's often not recognized directly. Almost 20% of the reproductive aged women attending infertility clinics show signs of premature ovarian aging. This decline has been very profound from the last 2 decades, where we see a lot of premature or ovarian insufficiency or premature aging in the early 30s, which would usually happen in the later or early 4th decade. But such increased fertility, female fertility, could be either because of the lack of knowledge on the heterogeneity of the ovarian reserve or the ovarian aging in the rural areas, or a tendency to delay childbearing in the modern societies. So in the present era, the existence of poor ovarian reserves has been unmasked due to an increasing acceptance of IVF as a modality of treatment for infertility. People do seek treatment early, especially in the urban population, and the diagnosis goes a little early. So that could be one of the reasons that it's been identified a little early. And it is believed that approximately 10% of the women undergoing IVF will show poor response to gonadotropin stimulation. However, the incidence may be much higher in infertile population, as many may never undergo complete evaluation or IVF. Now, when we look at the diminished ovarian reserve, it is most often noted in women in their mid to late 30s, but it may affect, as I told, the trend these days, it is shown to affect women at an earlier age, would be the later part of the second decade or the early of the third decade. It's believed that there is an accelerated decline in the follicular pool at an age of 37, 38, when it reaches a level below a critical of 25,000, it starts manifesting. Subsequently, there is very limited time for the conception with one's own egg. So if you see this chart here, the decline goes very steeper after the age of 35. And this phenomenon is accompanied by The decrease in the quantity again is accompanied by decrease in the quality. This could be because of the aging of the oocytes. Whereas the younger woman with a poor ovarian reserve, that is early or a premature ovarian aging, would have a better chances at conception. But recent evidences do challenge this, and poor ovarian reserves may be associated with low pregnancy rates irrespective of age, and definitely a higher pregnancy loss due to a poor quality of egg. Now, when we look at the important causes of diminished or poor ovarian reserve, if you could see there, this is how the aging starts. This is an optimal fertility, and then there's a declining fertility, and usually the steep starts at the age of 35. And the most important single determinant factor influencing success of any fertility treatment is age, and age alone. And this is in advanced age is invariably associated with a diminished or a decreasing ovarian reserve trend. The loss of oocytes from the ovary is a continual process, as we all know, which begins in utero. Ovaries in the female fetus contain 6 to 7 oocytes approximately at 20 weeks, and then 1 to 2 millions at birth. And then it keeps on coming down, even at around the 3 lakhs are present at the time of puberty, and then there is a gradual fall. The steep fall starts after the age of 35. So if you see this beautiful depiction, so majority of them have a very straight line, and suddenly at an age of 35. So that is the reason that the cutoff of 35 has been kept for determining the concept of advanced maternal age. And this is where there is a steep fall in the ovarian, or the fall in the oocyte pool or the ovarian reserves. The other causes could be idiopathic, could be the oncotherapy like chemo, radio, especially when it is given in the later 20s, because looking at the germ cell tumors, they are or whenever it's a prepubertal cancer, these are slightly resistant to DOR. But when a woman enters a reproductive health, the chemo and the radio have an intense effect on the decreasing the ovarian pool. The genetic mutations like FMR gene, the smoking, ovarian surgeries like endometriosis or cystectomy, autoimmune, mumps orchitis, or uvaritis, like how we have the similar concept in the ovaries, the mumps gets affected and reduces the ovarian pool, the galactosemia, tubal surgeries. Now, tubal surgeries, especially when they do a ectopic, the vascularization which goes from the broad ligament, from the small blood vessels which do supply the ovary through the broad ligaments get cut off, and this could be one of the reasons which enhances, may not be the only reason, but it would enhance the fall in the ovarian reserves. So if you look at this chart, it's very evident that as age increases, the probability of live birth decreases, especially steeply after the age of, say, 35, 34, starts from the age of 30. Now, this could be the other concept is as the age increases, the number of oocytes come down. And if the number of oocytes come down, as such, the live birth would be lesser, because then we talk about a cumulative live birth rate, which would definitely fall when the number of eggs are less, the embryos are less, and the chance of having multiple frozen embryo transfers is also less. Now, even this chart, if you see, it shows that as the number of eggs are less, the probability of live birth is less. So age and the number of oocytes both together are the reason for the predicting the low live birth rate in women who have poor ovarian reserves. So now this is a very good chart which depicts that female age is an independent predictor of live birth. Now, as I discussed in a few slides before, younger women would fare better. So if you look at this chart, you would see that a woman, a delivery rate per embryo transfer would become lower at the same oocyte retrieved, but at an older age. So if you look at this age, which is 39, and you look at this 30, so as the age advances, even if the number of oocytes have been, they fall in the same category, the transfer or the delivery rate per embryo is a little, if a woman is at a younger age, especially if she is less than 30 years. So as the number of oocytes increase, still the lines have been parallel, which so that age always has a better hand or upper hand in determining the delivery rate per embryo transfer. So, and also this is because, again, the reason is the probability of the blastocyst being euploid decreases with age. And that could be the reason that this all put one together, that if the age increases, the number of eggs come down. These eggs which come out or whatever are retrieved are again more of aneuploid, and hence the probability of forming a blastocyst, being a euploid one, also declines with the age, and less than 50% overall in women older than 35. So if you see there is a sudden fall in the euploidy probability as the age advances more than 35, and a sharp decline after the age of 40. So this is an analysis of around 1,220 trophectoderm biopsies from 436 patients, which showed this probability zone. Now, this is another chart which says that if you look at the the negative effect of the female age on the blastocyst, it is definitely progressive. And if you calculate from year to year, the fall or the decrease is more. So if you compare between 29 to 30, the fall is definitely less than the decline which is seen between 42 and 43. So year by year, the fall is more as the woman advances in age, especially it starts after the age of, say, again, 34, 35. So now coming to the other important causes of other than the age would be endometrioma, because endometrioma as such depletes the ovarian reserves being present there, creating a toxic atmosphere and damaging the oocytes. Other than that, the surgical excision also is known to cause a poor ovarian reserve. The mechanical pressure of the endometriomas on the ovarian cortex, the impaired vascular networks, alteration in the cortical stroma, the change in the microenvironment, these are all attributed to the damage caused to the ovarian follicles. Excision or pulling out the cyst could lead to the loss of the ovarian follicles which are there near the cyst wall. Genital tuberculosis is also one of the known causes for poor ovarian reserves, especially even in its latent form. It has been recognized as a cause of poor ovarian reserve. These women have been known to have abnormal ovarian reserve test. They show signs of poor response, and these do require high doses of gonadotropins for ovarian stimulation and reduced oocyte yield. So these are one of the categories for suboptimal or hyporesponders, which I'll be discussing in our further slides. The mechanism involved in the absence of obvious structural damage is not understood at present, but chlamydial infection is also known to cause an adverse influence on the ovarian response in those undergoing IVF. In recent years, uterine artery embolization for treatment of fibroids is again found to be one of the etiological factors for poor ovarian reserves. So whenever we advise a treatment for fibroids, for endometriosis, we have to always keep in mind, especially in an infertile lady, that we have to look at her ovarian reserves, understand that, and then take right decisions for the surgical intervention. The genetic mutations are another cause, which would be that we know that their familial history of premature menopause or early menopause is known to run in families. What could be the reason? Could be an altered expression of the certain genes in the cumulus and the granulosa cells, and this has been implicated as an etiology for poor ovarian reserves in younger women. Certain type of mutations like FMR gene are also known to be associated with reduced ovarian functional reserve in young women. The FSHR receptor polymorphism is considered an important cause of unexpected poor response. I would not say poor ovarian reserve, but an unexpected poor ovarian response in younger women undergoing IVF. Mutations, polymorphisms, alternatively spliced variants in the FSHR receptor, gene receptor has various or different effects on receptor function. What happens is these receptors have an altered way of functioning, and they bring about a structural change. So what happens is the lock and key mechanism gets distorted, the hormone binding ability comes down, the paracrine signaling, which happens when the molecules or the gonadotropin molecules go and sit on the receptor, gets disturbed, and hence the entire oogenesis, the ovarian stimulations go haywire. So this is one of the very important causes for suboptimal responders in IVF. Now, looking at the poor ovarian reserves, or the woman with poor ovarian reserves, how do we work it up? So the most important is whenever you suddenly find a woman with a poor ovarian reserves on the scanning, or she comes with a blood test of, say, AMH is low, what would you first do is go back and review her menstrual history. Look at the history of shortening of cycles. If she has a long cycles or prolonged cycles, a history of shortening of cycles behind would be one of the earliest indicators, and it would give you an idea of how long the shortening of cycles have been happening and how long the insufficiency or aging has started. The sudden intermenstrual bleeding or spotting again is one sign of reduced estrogen levels, would be an indication for a poor oocyte quality and a reduced number of follicles. So these are all small, or then abnormal uterine bleeding could be a abnormal oogenesis, and this could be hints which a woman would give you, and this could help you to get her evaluated early from the ovarian reserve test angle. You look at the baseline ultrasound. Other than the uterine characteristics, you would look at the ovarian size, volume. The Doppler studies are very important when you have smaller ovaries. So ovaries with a better Doppler would have a better chance than the ovaries which show very reduced Doppler flow. The antral follicular count is, yes, one of the very important predictive factor for ovarian reserves, and this has to be counted in both the ovaries on the basal scan is day 2 to day 3 of the cycle. The ovarian reserve testing I would be discussing in the next slide. And the genetic screening, yes, carrier screening, definitely when it runs in the families, it's one of the things you should be doing at as a first step. But karyotyping is, in an older woman may not be very significant, but yes, in a woman who is less than 30 comes with premature ovarian aging or insufficiency or a premature early setting in of a premature menopause, it is very important to look at a karyotype, because there are certain conditions like mosaics or Turners or could be fragile X where the reproductive life is very less. Even if you would want to get a pregnant, maybe it's not advisable that, or a pregnancy may be contraindicated, because these women have a high risk for cardiovascular complications. And first we need to understand whether they're fit for pregnancy, and then we may go ahead with the further steps like IVF or whatever the recommendations or whatever the treatment possibility she has to get pregnant. So it's very important to consider karyotype in young women, especially less than 30, to rule out Turner mosaic or Turner or a mosaic. Now coming to the ovarian reserve markers. So these are the ovarian reserve testing, which includes a basal day 3 follicular stimulating hormone, antral follicular count, anti-Mullerian hormone AMH, basal estradiol levels, ovarian volume, blood flow, basal inhibin levels, and basal ovarian volume. So when we look at the hormones, an early follicular or a cycle day 3 FSH cutoff of greater than 10 has a sensitivity of 80 to 100, but a lower sensitivity of 10 to 30 in predicting poor ovarian response to stimulation. So the specificity is very high, and if it is high, yes, then we know that it is going towards a reduced ovarian reserves or a premature early fall in the ovarian reserves. AFC is one of the most predictable factors, because but it has to be done by a experienced hand and a person who knows how to do an AFC, because it's a lot of person to person or variability is noted, and this could be one of the reasons that AFC needs to be done properly in a proper setup. And if AFC is less than 3 to 4 follicles, it has a sensitivity of 9 to 73, again because of the it could be because of the variations in the person who's doing it, and a specificity of 73 to 100% in predicting poor ovarian response to ovarian stimulation. Early phase estradiol. Now, if you look into the studies, it has a very limited utility, but if you really go into the physiology of ovary, so in a woman I would always look at it like in a woman who is a diminished ovarian reserve in an early or a late stage. So in an early, there is early recruitment of the follicle, and this woman may have a little higher E2 on the baseline level, that's day 2 or day 3. But as she falls down the slope into a later stage of the DOR with still falling down of AMH, this E2 again would be lesser. So she would have a prolonged cycles, then this E2 will be lower. So sometimes if you look at the estradiol, and if it is a little more on the day 2, day 3, it could be that these cycles are going into early recruitment or early shortening of cycles. And this is one of the hints that it could be going into a early premature aging or premature fall in the ovarian reserves. Ovarian volume and blood flow, as I already discussed. Now, in short, in a very good pictorial diagram, this would be the follicles which look at pre-antral which secrete AMH, and hence this is one of the most important predictor or most commonly used, and I think is the only one used these days for predicting low ovarian reserves. The problem with the AMH and the inhibin is both are very sensitive markers, but this comes into the blood very late. The assays have not been very well standardized, and hence AMH is more dependable these days, as the assays are very standardized, and there are newer assays coming out with which give us more sensitivity and specificity regarding the poor ovarian reserves. Antral follicular count is, yes, definitely one of the most important, but the only problem is it's a very observer dependent, and observer bias can happen. So this is seen at small antral levels, whereas it's the large antral levels which secrete the inhibin, and the estradiols, again, as I told you early, the early recruitment, the early rise in the estradiol. So this one of the newer studies came up with a tool, just came up 2 months back, with a tool for predicting ovarian reserves based on AMH and age, and it was a retrospective cohort study which said that the main effects of AMH level in the age contributing in for prediction to contributing to the prediction of poor ovarian reserves were 95 and 1.8% respectively. So when you look at the AMH and the AFC, so you can tell that these are very good, have a very good sensitivity, and the predictors of poor response, the predictors of excessive response, and they have a very accurate prediction or a sensitivity and the specificity to tell us about the predict the ovarian response. But these are not the predictors for the live birth rate, because one good euploid blastocyst, even from a low ovarian or poor ovarian reserve, gives you a good chance to have a pregnancy and a live birth rate. So these are only predictors of ovarian response, but not the live birth rate. Now, looking at what could be the criteria which came up with the ovarian poor ovarian reserve. So earlier there was no proper criteria, but in 2011, the Bologna-Eschrey came up with the Bologna criteria, wherein there were at least two of the following three characteristics should be present. That would be an advanced maternal age or any other risk factors for poor ovarian response, previous poor ovarian response that is less than 3 oocytes with conventional stimulation of about 150 international units of FSH daily or more than that, abnormal ovarian reserve test like AFC of less than 5 to 7 total, and an AMH of 0.5 to 1.1 nanogram per ml. Now, 2 episodes of poor ovarian response after maximal, that is conventional ovarian stimulation, are sufficient to label a patient as poor ovarian responder. The Bologna criteria, they had some critics or criticisms to it. It was basically designed to select a homogeneous group of patients based on the oocyte quantity for testing in prospective randomized controls for different strategies. But it did not presume to distinguish between the alterations in the oocyte quantity versus the quality from assisted reproductive technologies. Recurrent poor responders cannot be homogeneous with regards to the pregnancy outcome, and hence in 2016, Eschrey again came up with a Posidin Posidin classification for basically low prognosis group. So this went into a nearly more detailed stratification of low responders from a concept of poor ovarian response to low prognosis concept. So this Posidin was developed so that we don't label them as, defining them as low prognosis, because there could be a normal responder who looks a normal responder but a low prognosis patient, rather than calling them a blanket word of poor responders. So subdivision for the Posidin classification was based on age, pre-stimulation ovarian reserve, and the previous cycle performances. In practical terms, this allows the distinction into two main categories. One is the expected POR, that is the poor ovarian reserves, that is a group 3 and the group 4. So if you look at this, group 3 and the group 4, I'll come back to this. And one is the unexpected poor ovarian responders, that could be the category 1 or the group 1 and the group 2, which is actually poor ovarian responders or suboptimal responders. Now, these category is which needs to be targeted, because this would definitely give us better results than the group 3 and the 4. And these ones are sometimes deceiving. They have normal pre-stimulation characteristics, but when they start stimulating, they respond very suboptimally or poorly to our normal or conventional ovarian stimulation, and hence they're also called as hypo responders or suboptimal responders. But when you look at this Posiden's low prognosis group, now these are the hypo responders or the suboptimal. So if you see that they are young, they have a better AFC, they have better AMH, so they could be having a 3 AMH and a 10 AFC. They have an adequate ovarian response reserve, but they yield low or count, or they respond poorly to the stimulation in the IVF. These are again the older group who look good, but they again have a low response or suboptimal response. This is the category where it's a young woman with a low ovarian reserve, that's a poor ovarian reserve. This is, or an older woman with again a poor, this is an expected category. This we would call them as an early or a premature ovarian insufficiency category. This could be a normal aging insufficiency category. So this is very important to, this made a prognostication for poor ovarian responder very clear when we talk about, when counseling the patient or deciding the next step for the ovarian stimulation. So with this, if you look at another category, this could be the suboptimal and the poor. So if you look at the normal, so this is the normal responders, this is the high responders, and then this could be the suboptimal, which is between the poor and the normal, and the poor responders. Now, again, this female influence on the age, I've already spoken, could be that this category now, if you look at, we have always seen it as a poor or suboptimal responder or hyper responder, and this is poor ovarian reserve. Now, look at this category would be young women with euploid status, that is low aneuploidy risk. And you look at this category, which is 2 and 4, which are more than 35. So this is high embryo aneuploidy risk. So this is how you can clearly understand Posiden, and you can understand how to prognosticate your patient. So you have young suboptimal, you have old suboptimal, you have young but expected low. This would do definitely better than this, and in some cases may do better than this, because these are the euploid, more euploid category than the group 2. So you'll understand where your patient falls, and it is easier to go ahead with the next step for the IVF or the ovarian stimulation. Now, in the prevalence of the low prognosis group, the majority were found in the group 2, that is expected that the group would have a low prognosis, and the non-Posiden was 53, the Posiden was 47, and in this major contribution was the women who were more than 35. Now, we were discussing about how we would go ahead with the Posiden criteria. That is, step 1 would be the stratification, the step 2 would be the estimation of the minimum number of mature oocytes we need to have 1 euploid blastocyst, and the third one would be how the treatment strategies to individualize the oocyte number. So coming to the first step is how do we stratify? So when you look at an ovarian marker, and you have, it's very simple. You look at the ovarian markers wherever you have a doubt, get the ovarian reserve test early, maybe in first cycle 1 or the cycle 2. If they look abnormal, look at the age, and if the age is, you can categorize less than 35 or more than 35, and then you can categorize into group 1, group 2, group 3, group 4. So this is a younger age, this is the older age. If it is adequate, the ovarian reserve, but they have never had suboptimal low oocyte number previously, they've never had it, they can come into the non-Posiden group. If they have a suboptimal response earlier, then again look back at the age, and then you can classify them so that you can plan your treatment or counsel the patient accordingly. Now, there has been an increasing, right. So this is a novel predictive factor, again, a model to estimate the mature number of oocytes required for obtaining 1 euploid blastocyst for transfer in couples undergoing IVF in vitro fertilization. So when you look at this, there were, so this is the lasso method, this is the ART calculator. So when they did a calculator, they found that 11 mature oocytes are required to obtain 1 euploid blastocyst in transfer. And this is at an age of 37. And in case you have 7 mature oocytes, so having 1 euploid blastocyst with 7 mature oocytes, the chances is 54%. So this was how they predicted that this could be the number of, it would be basically a counseling tool to understand that how many expected euploid blastocysts you would have in a particular patient. So this was the ART calculator which came up. And now coming patient-oriented treatment strategy to achieve the individualized oocyte number. So our main goal would be definitely to maximize the oocyte yield, increase the chances of having at least one euploid embryo for transfer, and hence definitely increasing the implantation and a better take-home baby rate. So what do you look at when you're individualizing is the selection of the right protocol. Either it's an antag or an agonist protocol, the gonadotropin type, the gonadotropin starting dose, which is usually considered either the standard gonadotropin is usually 100 to 225 to 300 ideally. The gonadotropin dose adjustments during ovarian stimulation, either at the start or the mid, the type of the trigger of final oocyte maturation, and the type and the duration of the luteal phase support. So when today we'll be just talking about the low prognosis group. So when you talk about individualization of Poseidon 1 and Poseidon, these are hypo or suboptimal responders. Now the difference between these two, you'd know in our next few slides, would be that when you want to understand ovarian hypo response. So first we need to understand the concept. What could be the concept of ovarian suboptimal response would be to know what is FOI, that is follicle to oocyte index. Now there are two concepts here. One is fault rate, that is follicular output rate. So when you have say 20 follicles, which you are expecting more than 15 would yield you oocytes, you get a fault out of 20, you get say 18 or 15 is an ideal fault rate. So if you get 20 out of 20, it's like 100% fault rate. If you have a fault rate less, that could be the performance clinician or some oogenesis issues where you have a low fault rate. But when you look at the follicle to oocyte index, that means that it is compared with the baseline AFC count. That is your antral follicular count, which would you look at like you look at here at 15, but you get say somewhere around 5 or 4 or something like that. So this could be where, you know, the FOI, the normal FOI is more than 50%. So here, if you look at, you would have 15 to 20, you get 4 to 5. So this is where the FOI is less than 50%. Now, if you look at this category, you have good number of eggs, you get good number of AFC, good number and good number of eggs. That's good. If you have less number of follicles, say you have 5 to 6, but still you get 5 to 6 oocytes, that's a very good FOI. That's a normal FOI. But if you have good number of AFC and you get less oocytes, or if you have even low, like 3 to 4, and you get say 1 to 2, then it would again come under the low FOI. And this is very important. So this could be that the reason to get the low FI could be a low gonadotropin starting dose, could be some environmental factors, could be an asynchronous or not a very good cohort which has been picked up for the IVF stimulation, or could be technical issues involving the final triggering, or the technical or the experience issues with the oocyte pickup. So this is very important to understand that is ovarian hyporesponse really an hyporesponse? So this is how we have to look back at what could be the cause for a hyporesponse. So this picture is very clear. So here you have a normal FOI, even if it's a good ovarian reserve or a poor ovarian reserve. And this is a good ovarian reserve and a poor ovarian reserve, low FOI patients. So now coming to the first, the suboptimal or a hyporesponder category, that is group 1 and group 2. So what could be your major management strategy here would be that first to look at what could be the reasons, as we discussed already. Correct whatever can be there. So right trigger, proper pickup, technical issues should be corrected during the pickup, confirm your suction, everything, you know, the right things should happen in place. Then your treatment could be if you have, antagonist treatment with a proper priming, trying to make the synchronous cohort when you're starting the stimulation, taking care that you take the right or pick up the right cycle for the stimulation. The studies have said, there are many studies which say RFSH has a preference over the combination, but whatever gonadotropin you use, the recent ISHRE guidelines says that there is no difference in any of the gonadotropins used. You can have to just increase the dose of the FSH, the recombinant FSH you use. And yes, in such cases, supplementation with luteinizing hormone, either as a combination to recombinant FSH or a HCG-driven activity, and addition of growth hormone also has been recently studied in such women, would give you a better yield of oocytes. The trigger can be considered as a dual, because maybe they need more of trigger molecules to be, or the receptors would not be doing a good job. So here maybe dual trigger would work, and fresh transfer if there is no risk of OHSs, and elective cycle segmentation and FET if there is a risk of OHSs. PGT is only recommended when in younger women, only when there is a genetic abnormality suspected or a genetic abnormality in the family. Now here, if you look at the measure of the success, this woman at a younger age would have to have one euploid would have require a minimum of 5 mature oocytes. Whereas in an older woman, the priming, or these are again the women who have a good reserve but maybe having a poor quality. So the difference between these two would be that you may need more, that is 10 to 12, because considering the aneuploid factor, you may need 10 to 12 mature oocytes to get one euploid blastocyst. And this category, you will have to be very cautious with increasing the gonadotropin dose, because these are a little poor quality oocytes, which would not do very well with a very increased dose in this category. And diostem is one thing you can consider, that having 2 stimulation cycles in one menstrual cycle, and picking up eggs, oocyte retrieval in the follicular and the luteal phase 2. These women again benefit with a dual trigger, and hence may be considered for a dual trigger. So now coming to the addition of luteinizing hormone in assisted reproductive technology, this was a systematic review wherein the population was investigated, was a hyporesponse, advanced age, co-treatment with antagonist, profoundly suppressed LH level, normal responder with risk of OHSs, poor ovarian responders to ovarian stimulation, including the ones who met Bologna, and the main outcomes were implantation rate, number of oocytes retrieved, the live birth rate, ongoing pregnancy, fertilization rate, and the number of mature oocytes. And then they showed here that in hyporesponder, that is group 1 and group 2, the combination of recombinant FSH LH would yield better number of oocytes and better implantation when compared to the FSH alone. Now, this could be that LH is very much required for the final maturation. So, and that would definitely, LH is known to change the microenvironment of the ovary. It is known to increase the insulin-like growth factors, reduce the insulin binding receptors, and this is how LH may increase the microenvironment and could give us a bit better quality of oocytes. Though there are a lot of studies which do say that it doesn't matter, but yes, if supplementation of LH would definitely help us get better number of oocytes, better quality of oocytes. Now, this is another study which again showed that the recombinant LH in hyporesponders, these women would definitely, if you look at the clinical pregnancy, the oocyte number, the implantation, all were doing better when a combination of recombinant FSH with recombinant LH was used, or it could be a direct HMG or a HCG driven HMG. Now, it's very important in this category to have an appropriate gonadotropin dose, and that's the major critical step to have a better number of or adequate FOI. So the type of gonadotropin we already discussed. The FSH dose, here you could definitely go beyond 300 to 450, looking at the BMI of the woman, LH supplementation as we discussed already. So this woman, if you increase the dose, especially the group 1, would definitely yield us better. And this is very important to understand this category and go on a high dosage to yield better oocyte quality, keeping hyperstimulation in mind. So now coming to the next category is the poor ovarian reserves. So this is posted in group 3, group 4. So this younger, that is a group 3 is younger age. So poor reserve, but expected to be a bit better or good quality. The group 4 would be a poor reserve with poor quality, more of aneuploidy. So this again has asynchronous development. Here it's a high aneuploidy rate. The genetic polymorphisms never change though. Now this, wherever there is a poor quality oocyte, long protocols have shown to have better quality of oocytes, though the numbers may be here and there, but the quality of the oocytes may become better with the long protocol, and usage of both the HMG, the FSH and the LH. The addition of some supplements like androgens or growth hormone has been shown in some studies to have a variable response. There have been studies which promote them, and there are studies which say that they may not have much shown to increase the microenvironment or the intrafollicular hormones like growth insulin like growth hormones or something which are pro oogenesis and which have a benefit of may help in having a better quality of embryo. So this category, again, if you look at in the group 3, because they're young, again, you need only 4 to 5 oocytes to get one euploid, which is similar to the group 1. And here again, you need 10 to 12 oocytes to get one euploid. And this becomes a very much of challenge in a poor ovarian reserve to get so many eggs in one sitting. And so you can look at a duostem. So what is a duostem is you go ahead with a stimulation with the HMG or a combination of LH, do a routine start antagonist, give a trigger at the right when the follicles have reached 18 to, the lead follicle is 18 to 20, do the pickup, then stop for 3-4 days. The trigger has to be an agonist trigger. Then go again with the stimulation, add again antagonist, and then again trigger and get a pickup. So this would basically cut short, though the guidelines from the ESHRE do say that it should be done only in selected cases, especially people who have no time, have to go back to their countries, they've come for treatment, or cancer patients. But it could be definitely opted to for women who want to cut short or have less time for stimulation. And this would definitely increase your yield over one stimulation cycle. So this again from the same study, again meta-analysis, which says that addition would give us better implantation rate, again improving the implantation. Now, when we talk about addition of the recombinant LH or HMG, do we start it at the start or do you start it on the day 7 or the day 8? So these all studies have just compared that addition from day 1 has or started on, some have started on the day 6 or the day 8. But when you look at the PERSIST trial, this were for women, older women undergoing stimulation, ovarian stimulation with a conventional method. They compared with group A was recombinant FSH plus LH 2:1 from day 1 and recombinant FSH or for the first 5 days, and then add the LH or change to HMG in the same ratio 2:1 in the group B. So one was starting dose adjustment and one was a mid-cycle dose adjustment. So this they saw that the clinical pregnancy rate, the per started cycle, per embryo transfer, again the number of embryo transfers, everything, those were kept same. But when you look at the clinical pregnancy per started cycle, they were better than the category where the HMG was added or an LH was added later. So this was again the trial by the SPART again, which said that efficacy of the follicotropin alpha or the lutotropin, again a randomized controlled trial in poor ovarian, the SPART trial, which said that no statistical difference in the number of oocytes retrieved during course, patients receiving recombinant RFSH or RLH than those receiving the FSH alone, as low average number of oocyte retrieved in both the groups. But almost all the studies accept the fact that LH supplementation may reduce the rate of the apoptosis by increasing or improving the microenvironment, and this could be a marker of oocyte quality that is positively correlated with age, and this is increased by all this epiregulin or amphiregulin upregulation. So definitely LH is a hormone which is used for maturation and would definitely help aged oocyte or oocyte of poor ovarian reserves to fare better in the embryology. According to the ESHRE, but as I said earlier, there is insufficient evidence to favor the use of one type of gonadotropin over the other. Coming to what the pre-treatment or the adjuvants use, there are no significant or studies which say that we should use, or there are no studies which say that it would be harmful. The pre-treatment usually which we use to prime the ovary or get the ovary into a synchrony is contraceptive pills, which would be tried to be used at the minimum. The best would be to prime with estrogen progesterone in the luteal phase or just before the menstrual cycles for a week or 10 days, which would definitely not suppress it to a higher level and would yield as a better success rate in fresh transfers. The adjuvants like growth hormone, DHEAs, testosterone, aspirin are being used widely, whatever the recommendations say. People do say, and you ask me, I would say that I have seen good results with the growth hormone and the DHEAs. though there are evidences supporting it, have been very inconclusive. But you can use these to improve the oocyte number. The latest lot of studies, I think there's lot of data in the recent 4 or 5 years about PRP. So PRP, we all know, is rich in growth factors, cytokines, and this induces tissue generation. It has been used all over the body to cause tissue generation, from the joints to the eyeball to the hair, and now to the ovary, the endometrium. But what we need to understand is all the tissues are regenerating, whereas oocytes have been given from the birth, and they are not going to be created again or born. They're not going to regenerate. We can only try to enhance or the quality of whatever is left behind. So this PRP would promote or create a better follicular development in vitro excuse me, and is utilized in small case series as a potential treatment for women in POR. Few studies have shown that intraovarian injection of PRP in women has resulted in the increased number of M2 and cleavage stage embryos. However, little is known about the effect of autologous PRP on the oocyte and the embryo quality. Now, this was the first trial, Saffronidis trial, which talked about PRP, and they have found that they could have one baby, live birth rate till now, and they're still, I think, continuing with their trial. This is one of the trials which with our own Dr. Manjula Nagani has published, and have shown that it has definitely a better effect on the oocyte quality. It would not reduce may not improve your AMH, but it would definitely improve whatever the quality, or may improve, help you to get one mature oocyte extra. So this is again one study which says that would be considered, might be considered. So majority of the studies do say that might be considered for poor ovarian response. But what I would like to tell here is, it's not that it's a poor ovarian response and you do a PRP and you expect a certain, effect or response to it. It depends on what stage or what is your eligibility criteria when you do a PRP. There are many studies keeping different criteria. So, when you have, I always look at a woman in a slope of the fall of the, so if she's in an early phase, created be in a good microenvironment, slides down. So it's a late do where it has crossed 20. You may not have a response with PRP. It will be that you are not much of help. Suggest the right candidate for PRP rather than just treating it like treatment for ovarian reserve. So in ovarian reserves, the predicted has a
Nishan? Hello?
Yes, Bharat.
I think disconnected, no, ma'am?
Yeah, ma'am got disconnected.
I think because of the poor network issues. Let us wait for some time, because she told me.
Yes.
Okay, I think it's we are on live only. I think I would like to pass this message to all the requested delegates, respected delegates, that madam has joined earlier through Wi-Fi. Maybe due to poor network connection, it has got disconnected. Let us wait for some more time. If she joins, we will continue, or else we will close. We will wind up the session.
Okay, so you get information from them till then.
Yeah.
Delegates,
I'll try to get.
Please wait for a few minutes. There is some technical issue from. Okay, ma'am has joined.
Ma'am, you can continue, ma'am. Hello, ma'am. Can you hear us?
Hello, ma'am.
Yeah, I think I got disconnected.
Yes. Please continue, ma'am.
Yes. Yeah. So I think this is the last two slides. So it's important for us that individualized understanding that in Poseidon 3-4, where the compromise, because the numbers are less and hence the quality is also expected.
Dr. Runa Acharya, can you share your screen, please?
I'm sharing my screen.
Yeah, can you just share, ma'am? Yeah, yeah,
Can
it
you
has
see?
come now. Yeah, please continue.
No, it's not working. Yeah. So this is very important for, I think you can hear me now.
Yes,
Hello?
ma'am. Yes, you can continue.
Yeah. So this is very important to know that this compared to the group 1 and the group 2, where you increase the dose and it's going to do wonders, it will not work in group 3, 4. So this is very important for us. That's why I say it's important for you to understand what is the prognosis of your patient who comes to you with a poor ovarian response. And extremely high doses of gonadotropins have been used for decades in poor ovarian responders, especially the category 3 and the 4, will just going to increase the cost treatment burden. Augmenting dose beyond 300 will not contribute to enhanced ovarian response, and it is a myth that increase the dose next time, except when it's proven suboptimal or hyper responsive 1 and 2 category. Clear evidence says that these patients have very few recruitable follicles. Of the dose administered only support the cohort of follicles sensitive to stimulation without generating follicles de novo. So it's very important for us that too much of gonadotropin would be lethal to the oocytes. So very important for us to individualize dose, especially in Poseidon 3 and 4 category. So with this, I would like to conclude looking at the efficacy and safety. There is evidence to favor the use of one gonadotropin over the other. Decision on the gonadotropins are therefore still mainly based on the clinical experience and preference, local availability, cost, and convenience. In future, I hope that pharmacogenic genomics with art intelligence may ovarian stimulation success and guide decision making on the design of treatment and adjustments of doses. Thank you so much for your patient hearing, and I'm sorry for getting disconnected in between. Thank you.
Thank you, ma'am, for giving all the detailed information regarding this topic of POR. So we received two questions. First question is, can androgen pre-treatment with DHEA be helpful in oocyte yield in POR condition?
I did mention that there are many studies for and pro and against DHEA. Some say they have no effect, but what I personally feel is in a woman who has an early DOR where the androgens, see, intra-ovarian androgens or intrafollicular androgens are very important for maturation of the oocyte and better embryo quality. So I do supplement with DHEA. The thing is, all folliculogenesis takes 3 months. So we need to give them some time. We cannot rush up, expect that it will work in a month. So where women have taken 3 months and more, I've seen things happen good. Also, the other way out could be that you can test your testosterone, female testosterone. So in women who have low testosterone, DHEAs may help because they would have a lower androgens and they would help with the DHEA supplementation.
Okay, ma'am. There is one more question that whether these patients suffer similar symptoms like menopause, for example, hot flushes, night sweats, loss of sleep, palpitation, etc.
Ovarian insufficiency, that's what the menstrual you can always have her normal aging. Because symptoms appear start manifesting the 10 years before 32 when they have start having low E2 or the low A match. They do have E2, and this estrogen, if low, it would start with symptoms like hot flush, and it would again irritability, mood swings, letharginess.
I think we lost connection with ma'am again. Bharat?
Yes, Shant.
Ma'am, we again lost connection with doctor.
Let's wait for a couple of minutes.
Yeah.
Then. Yeah.
Okay.
Yeah,
Hello,
Bharat.
ma'am.
Yeah.
Ma'am, we were not able to understand. There was a very poor
Yeah.
connection.
See,
So can we ask you? Can hello, ma'am.
yeah.
Ma'am, please repeat that answer. Uh, yes, there was disturbance
Thing
in
is,
connection.
when women start, yeah, when a woman starts showing low AMH and the low ovarian reserves, definitely the estradiol levels, that is E2, is low. And when E2 is low, she definitely starts showing symptoms of perimenopausal changes. I think 8 years before. So, some women who have menopause at say 40, they may start showing symptoms from 30. So this is one of the earlier signs to understand that yes, the aging has started. And the similar symptoms, like how it is happening, is be that how they show the signs of perimenopausal changes like hot flushes or mood swings, irritability, and then definitely detrimental on the bone too.
Yes. And ma'am, one more question that what are your thoughts on ovarian rejuvenation procedure for improving low MH?
Yeah, that's what I told. I think the last one was that it's very important for you to decide when to send a patient for ovarian rejuvenation. So suppose you have a woman earlier DOR, that is like she has a better chance with you have some few follicles and she's not getting very good quality eggs, or the quantity or the FOI is coming down. So that could be that the microenvironment of the ovary is not good. So such woman will be benefited with PRP. But if you look at PRP at a woman who is having an FSH of 25-30 and expect that it will make some miracle, it's not going to happen. So you have to really understand that at what point a woman has to be sent for a rejuvenation. It does help women who would be early. I always divide my patients into early DOR and late DOR. Early DOR usually benefit, especially if they've not had a very good IVF cycle. Like you can definitely send them for a PRP, and it would give you, even if it gives you extra one good quality egg, it would definitely make a difference.
Thank you, ma'am, for giving all the answers to these questions. And we are glad to have you on our platform for today's webinar. And we would like to have more sessions with you in the coming future on Shield Connect platform, ma'am.
Thank you so much.
Thank you
Thank
so
you
much,
all
ma'am.
for your patient hearing.
Thank you, ma'am.
Thank you.
Yeah, thank you so much, ma'am. And Nishant, you can stop the live now.